Good evening. Thank you for joining us for the webinar, Evidence-Based Fraud and the End of Statistical Significance. This webinar forms part of the Rural Health West 2020 virtual conference. Before I hand you over to your presenter for this evening, I'd just like to run through some brief housekeeping. If your audio is not coming through too clearly, you may prefer to switch to audio via your phone. These numbers will be listed on your dashboard. Remember to enter the PIN number too. Everybody has been placed on mute to minimise background noise, but we would still love to hear from you. Please enter any questions into the question box, which you can also see on your dashboard. The presenter will look at these questions at the end of the webinar and make his way through those questions, which he can. This session will be recorded and uploaded to the Rural Health West website under the Virtual Conference 2020 banner. I'll now hand you over to your presenter, Dr. Anand Senthi.
The topic tonight is a talk called Evidence-Based Fraud and the End of Statistical Significance. And it is a talk that will hopefully change the way that you interpret evidence-based medicine forever. So just a quick disclaimer, this talk is only for health professionals. So this was kind of talk was advertised in various forums, and if you're not a health professional, or then this is probably not for you, particularly if you're from the general public, because you A, won't understand it, and B, there's a great chance that you could misinterpret what I say for the worse. So health professionals only is my advice. So what is this talk about? Well, the problem is there is a current scandal in medicine that most of the published research findings that we've published basically in the history of time are false, which is obviously a major problem. And why is this? So there's a few reasons which we're going to go through, but obviously there are some substantial corrupting forces within our industry, but more important than that is there was actually something grossly wrong with our scientific proof. And the actual methodology that we have been using is incorrect. And moreover, just as a general concept, we've forgotten that statistics is just guesswork based on a series of assumptions that usually actually don't hold true. So we're going to go through this. It is kind of like being in the Matrix. I'm Morpheus, and I'm offering you the red pill or the blue pill. And if you choose to take the red pill, you won't be able to go back from here. So your only chance to take the blue pill is to hang up now. So we're going to start with John Ioannidis' kind of famous paper, I think it was 2005, which was why most published research findings are false. So already 15 years ago, he was telling us why our data was inaccurate, and that everything we were publishing, all the positive findings suggesting that there was some treatment benefit or some benefit of some procedure were generally false. And this is when we were calling it statistically significant, P less than 0.05. Generally, these findings, despite B less than 0.05, were false. And one of the things he pointed out are the features that made a study more likely to be false, finding more likely to be false, was if there were very small effect sizes. So if you see an effect size, so from our perspective, a clinical effect size, that's very small, you're talking about NNTs in the, near 100, these types of numbers, or NNT of 50 even, it's a very small benefits. They are actually quite unlikely to be real findings. So I call that the EBM double whammy, because firstly, you've got an effect size that's so small that we really don't care about it anyway. And secondly, we have the fact that it actually probably isn't true. So we don't care about it, and it's probably not true anyway. So that's the double whammy. And where there's a greater number and lesser pre-selection of tested relationships, and that's obviously about having loads of primary or usually secondary outcomes that you test, and by chance, one of them often shows itself to be significant and usually is false. Where there's greater flexibility in design, definitions, outcomes, and analytical models is quite important, and that's where we try and have kind of standard outcomes based on validated measures that we can't change. So you decide before the study what your primary outcome is, and you don't change it, and you don't change your methodology and how you assess things after the fact, which often happens. And if you get to change them, then that flexibility makes your findings less likely to be true. Obviously, conflicts of interest are a key factor, and it's been well documented that drug industry-sponsored trials have a huge risk of bias and likelihood of being false. And a big one that we tend to forget about that he mentioned then is that if the findings and the therapy is biologically implausible, it is very unlikely that almost regardless of your p-value, that this is going to be a true finding. And this feeds into something that we'll talk about later about the pretest probability before the study that is relevant to whether you determine this p-value to be of any relevance at all. So I just want a quick example of a study with a very small effect size. So this came out just, I think, last year, or probably last year, the year before, the Paramedic 2 trial of adrenaline for cardiac arrest in out-of-hospital cardiac arrest. And to cut to the chase, it was a massive study, 8,000 patients, and it actually found that adrenaline allegedly increased survival by a minuscule 0.8%, so an NNT of 112, with a p-value that wasn't that impressive at 0.02. Now, under this kind of world of statistical significance that I'm hopefully going to dispel tonight, they said that was a real finding or a significant finding. But this is, of course, the EBM double whammy. A tiny effect size is both clinically meaningless and also unlikely to be true. And the other problem with p-value calculations is when you have massive data sets, it's very easy for any difference between groups to be shown to be significant by this standard. That's the nature of the p-value calculation. It almost always shows significance when you've got massive data sets. So, and the other problem with the study, probably the bigger problem with the study, was that the outcome that they studied was really the outcome that we didn't care about. It doesn't really matter if people just survive. When you bring back people from the dead, so to speak, you actually need them to survive with a good neurological outcome. And in that case, adrenaline didn't make any difference. So, but despite this, you might think this is obvious that we should be not counting this study as supporting adrenaline. But I was at a conference where the ILCOR representatives were at the conference and were saying that they saw this as good evidence and were going to upgrade their recommendation on adrenaline to strong for out-of-hospital cardiac arrest. So this is kind of what we're dealing with even right now with guideline committees and how they interpret evidence. This is another important study that was published by Prasad. And what he did was he looked at the New England Journal of Medicine for 10 years in their original articles section, and looked at all of them and found that 1 in 10, or actually 1 in 9, I think, of those articles were actually reversals. So they were articles that they were published showing that, a previous article that was published that said that this is a new great treatment was wrong. That the findings we previously published were wrong. And that was, 1 in 10 of articles being published in the New England Journal of Medicine. Another obvious interesting finding was that 70% of articles reached positive conclusions, which shows a massive publication bias because most studies are generally negative. And if you're seeing 70% of that are positive, we're not publishing enough negatives. And certainly in the back then we were not. And then somebody took this further. So this group took this further from just the New England Journal of Medicine and looked at 3 major journals over a 15-year period and found about 500 published reversals. So therapies that we thought worked based on some significant p-value, and then we studied again and we were wrong. And it didn't work. And the problem is this 500 is the tip of the iceberg because it doesn't include, firstly, articles that are prevented and suppressed by conflicted peer review. So if you publish an amazing paper that shows some great new therapy or way of going about things, and people believe you, then you often can become an expert in the field. So when future people try and publish papers disputing your paper, you are one of the peers who gets to review their papers and therefore have the option to poo-poo it if you wish to, so it doesn't actually make it to publication. The other issue is that most findings that we say are significant never get tested again. We just go, oh, that must be true, and we never actually test them. So there's got a huge number that we actually haven't even studied that would probably be reversals. So why is this happening? Why are we so bad at publishing evidence that actually says what it says, that actually is what it says, that we say this is a study finding and it actually is true when most of the time it's false? So it comes down to bias and chance. Now, bias is the combination of all the factors in the design, data analysis, presentation that would produce findings when they don't exist, right? So that tend to produce, say there's something there when there's not something there at all. And this is completely different to chance, right? Chance is the variability that causes some findings to appear to be there when it's just basically chance causing it, okay? Now, the combination of bias and chance is what actually combines to make most of our studies findings to be false rather than true. So we're just going to go through bias first, and then we'll get onto chance, which is the area which is going to take the biggest shake-up in terms of what we thought we were doing being incorrect. So obviously funding affects bias, but without funding, even without an industry-sponsored trial, there are loads of internal, intrinsic conflicts of interest that can change the outcome of the study. And any researcher has a internal bias that they want their studies to be successful because it obviously promotes their career. It is something that they want because they believe in what they're doing, but also it links them to getting further funding and further research dollars. So there are significant motivators for there to be studies produced that have heaps of bias in them. And then there are just methodological errors that people make that create bias. And so we have to be continually focused on looking for these sources of bias. And unfortunately, some of them are basically undetectable. And I'm going to give you a few examples to show you what you can read a paper and still not actually be able to see the bias, which is concerning. And then where we have to probably always price in some bias when we're evaluating papers. And a really important point is that bias is independent of sample size and statistical significance. So people kind of think, sometimes you got a huge study and think that just makes everything better, but it doesn't. It doesn't change bias. It just essentially, propagates bias through a bigger sample set. So this is a picture from a paper which I'll reference in my show notes that gives you an example of a whole range of types of bias that can happen before the trial, during the trial, and after the trial. I'm not going to go through all of these, but the picture kind of says alone, how many different types of things can go wrong. I will give you some examples in a second. Now, just the ones that I've highlighted there: selection bias, channeling bias, which is a form of selection bias, and confounding. These are the only forms of bias that go away when you randomize, because that's another misconception, that with lovely randomized controlled trials, we get rid of all our bias, and we don't. We get rid of just a couple of causes of bias, and all the rest are still in play to ruin our findings. So I'll just give you a few examples, and this one's a really insidious one that it's an old one, but it's just a great example. It was one of the first things that opened my eyes up to the world of evidence-based medicine and the fraudulent world of evidence-based medicine. But there was a study called the HOPE study back in 2000, and one of the things it alleged to purport was that ramipril could reduce your risk of stroke independent of its effect on blood pressure. So what they did was they gave a low dose of ramipril, just a really small dose, and they measured your blood pressure and found that your blood pressure didn't change at all. Despite that, despite no effect on blood pressure, your risk of stroke went down significantly. And this heralded the magic effect of ramipril. They said that ramipril was just magically reducing risk of stroke, and no one knew why, and obviously everyone made up some reasons, but it had nothing to do with blood pressure, and therefore we should give blood pressure ramipril to anybody at risk of stroke because it was magic. And so unfortunately, a few years later, we found out that when they gave the ramipril was at a certain time, let's say 5 in the afternoon, and then they measured blood pressure almost 24 hours later, like an hour or two before they gave the ramipril. And because they gave a really low dose, the ramipril had completely worn off by the time they measured their blood pressure. Now, through the night and the rest of the day, it had reduced your blood pressure. And when you reassess this and measure it the rest of the time, all of that reduction in stroke was due to just dropping your blood pressure. And so this wasn't in the manuscript. There's no way of knowing exactly the time that they gave the medications. Few articles ever tell you, the exact timing a medication was given and when you measured something. But just in that alone, that completely produced the study finding a huge amount of bias that you cannot detect at all when you read that paper. And unfortunately, that came out years later, apparently by accident, when they were discussing another study, and people realized about the timing and were like, hang on a second, and that's when the jig was up. Other ways that you can bias a study just by study design, the IRIS cricoid pressure trial, which is a trial of using cricoid pressure, in my opinion, a defunct technique that is meant to reduce aspiration when you intubate somebody who is not fasted. And they did a trial and found that basically the risk of aspiration was identical whether you gave cricoid or sham. And it was a big trial, good trial, and basically showed no benefit that you could tell of cricoid. Like, it was a hands down, see you later cricoid. And unfortunately, if they treated this like a normal superiority trial, they would have said, this is not superior, this is not better, it shows no benefit, you're out of here. But instead, they designed it as a non-inferiority trial, which I won't go into the detail in the interest of time. But by doing that, by calling it that, it meant that they could say that cricoid was, I think the sham was non-inferior to the cricoid, and therefore cricoid is okay. So again, this is just a study design thing that introduces bias in how you interpret the study. And a big one is about changing outcomes in terms of your study design. So the whole point of a primary outcome is that it's the only outcome and it never changes, right? That's the concept of a primary outcome. And up to 1/3 of trials have been found to be changing their primary outcomes from when they pre-register it to when they publish it. And obviously the big suspicion there is that they're changing it because there's no benefit, and they find some other outcome where there's some benefit, and they p-hack and use that outcome instead. So and this was happening basically all the time before the clinical trials registry, and the clinical trials registry was meant to stop this, but it hasn't. So some pre-trial examples of bias we'll just run through. NINS 2 and ECAS 3 were the thrombolysis, the only two studies to allegedly show a benefit of thrombolysis for stroke, and they had different severities of stroke at baseline. So more severe strokes in the placebo arm, which is argued to have been responsible for the small benefit that was seen in those trials. Also, NINS didn't consecutively recruit patients, so they had equal numbers in the 0 to 90 minutes group and then 90 minutes to 180 minutes group, which is just impossible to do under normal circumstances, and no one's been able to replicate it. And so it was kind of an odd amount of selection bias, which could easily have affected the results. Another one I want to mention, because it just brings up the example of statistical adjustments that I'm very wary of, and we should always be wary of, is the contrast-induced nephropathy studies. So for a long time, it's been believed that if you give contrast with CT scans, it might cause kidney injury. And admittedly, that was based on some pretty old studies with I think mainly arterial contrast given for angiograms and things like that. But so there is reason to believe that maybe that isn't the case with newer contrast given with CT scans. Unfortunately, you can't randomize people to this because it's considered unethical to just give them contrast for no reason. So what ends up happening is you look at retrospective studies of people who got contrast and people who didn't get contrast. And unfortunately, the people who didn't get contrast are often sicker. There's a reason for the same study you've chosen as a doctor not to give them contrast. So they often have kidney problems already, or they're quite sick, or they have diabetes, and all these other issues that might be affecting their renal injury risk. And lo and behold, these two groups are so perversely different in selection bias that it actually looks like having contrast makes your kidneys better. It's renoprotective. It's so good, we should put contrast in the water supply. That's how good it is. And it's just an example of how perversely flawed these sample sets are because of the difference between these groups. Now, they then did some special, what I would like to call statistical hocus pocus, to adjust for all these known confounders, but none of the confounders that we don't know about, and were able to treat the data and say, actually, we'll get rid of all that, and there's no difference between the groups, and therefore contrast is safe. And that is a type of statistical hocus pocus that I encourage you all to be wary of, because statistics can't change the underlying huge differences between two groups that actually show an effect that's the opposite to what you're expecting. You can't just turn that away with statistics. That is not the power of statistics. And So now a couple other examples. During trial examples, we have, recall and interview bias. A good example is the old sentinel headache in subarachnoid hemorrhage. So, we all believe, or some people still believe, I think that, that subarachnoid hemorrhage often have this herald sentinel headache, a week before, that if we just pick it up at that point, we'll save them from the massive subarachnoid hemorrhage. And the issue is how we found out that data was we often did interviews. And firstly, if you just told somebody that they've had a subarachnoid hemorrhage, or let's say you're just interviewing somebody who hasn't, who's got a migraine, and you say, mate, do you reckon you've had a headache in the last week? And they're like, oh, no, I can't think of it. And then you tell them the next person who's had a subarachnoid hemorrhage, you say, you've got a bleed in your head. There is blood in your head. It's very serious, very serious. Now, do you think you've had a headache in the last week? It's likely that person might think differently and recall differently because they know they're bleeding in their head. And so that's an example of recall bias. Interview bias takes it another step further, is when the migraine person answers and says no, you say, okay, check. And when the subarachnoid hemorrhage person answers and you know they've got a subarachnoid hemorrhage and you believe in the sentinel headache theory and they say no, you say, oh, are you sure? Do you want to think about that again? That's interview bias. And so it's one of the reasons that we need harder endpoints in trials, because as soon as you let somebody subjectively assess something in words or in appearance, you introduce potential for bias. And that's the other issue with doing retrospective studies. Now, misclassification of outcome or exposure, not surprisingly, thrombolysis comes up again. In ECAT3, they classified the outcome, which is a modified Rankin score, and used a very strange a set of classifications. So if you look at the score, this is a commonly used score to look at disability. And if you were to cut this into two, it would make sense if you just make it into two groups. So probably cut it there, 0 to 2 and 3 to 6. So kind of with minimal disability and the guys with significant disability. Whereas they decided to cut it between 1 and 2. And when you do that, you group very intuitively people with slight disability with people who are dead. Now, that doesn't obviously go together for me. Slight disability, dead. But that's what they did, and somehow manufactured a p-value of 0.04, which is, like we see, just borderline from this old concept of statistical significance. And if you know what the fragility index means, it means that if one single person changed their outcome between the groups, that would have made that a p greater than 0.05. So it was, absurd. It's absurd even in the old way that we analyze evidence, which I'm hopefully going to change us from going forward. Now, citation bias. This is the big type of bias that we can't, like I talked about the Hope trial, showing you an example of a study design bias that you can't see. You can't read it in the manuscript. But the other one that you can't see and you can't read is citation bias, because researchers have no obligation to report results that are unfavorable, that they don't want to report. So they may have findings that are against what they are trying to suggest that they won't report, such as the negative trials, or even trials that show harm. They have no obligation to publish. And so, just to kind of show you an example of that, Ioannidis has just published a recent paper that looked at all papers published between 1990 and 2015, and 96% of published p-values were below 0.05, which is incredible, because obviously there will be all sorts of outcomes measured in any study, and if you're seeing almost all of them less than 0.05, it means that you have not published basically all of them. Like almost all of them have been published, and you've taken the tiniest selection and published them. Not one person, no one researcher, but every researcher in that group of those 25 years. I mean, that is just astonishing, and it tells you how much you're not seeing, how many outcomes, how many papers you are not seeing. And what we can't see, people would say we can't judge, but I will dispute that shortly. Now, the clinical trials registry was meant to kind of get past this, right? The idea with the clinical trials registry is that as long as you register your trial on the registry, the major journals will allow you to publish it. But if you don't register in the registry, they won't. Unfortunately, there's still problems happening. One is that a third of trials that are registered still aren't being published. So you don't even know what happened to those trials and all their outcomes. And they could have been people dying or having no benefit. We'll never know. And of course, most of those were industry sponsored. And the other issue is that still, apparently, and shockingly, some of these major journals are accepting trials that were never pre-registered in the first place, which defeats the entire purpose of the clinical trials registry. Now, that's the end of bias, and that's most of the stuff obviously you already knew. I just gave you some examples to hone in the points that you'll see later. But chance is the big area of change that is coming and that needs to come because the way we've approached chance is unfortunately wrong. So the thing about chance is that even if you have a trial with zero bias, right, you've got the perfect trial, which in itself is almost unheard of, and you know, I still believe that going forward we have to price in some risk of bias in every study because of the stuff that we can't see, we talked about. But let's assume you had zero bias. Then the only other thing that should account for any differences in your groups, if it wasn't the actual thing that you're studying, like the treatment, is chance. Right? So, and the simplest example of chance is the old head and tails. You flip a coin, and if you flipped it 10 times, you'd get, you know, you might get 7 tails and 3 heads, and go, wow, that's silly. That's obviously from chance. So if you flipped it the whole 100 times, you'd actually find, I think there's 56, you know, tails and 44 heads. Now, you might see a study with 56% to 44 and think that's a real finding, but you can easily show that where there's no difference between the probability of getting heads or tails, you can get 56 and 44 in a group of 100. Now how do we deal with that fact that you can have that chance in there and it might be accounting for the variability that we're seeing? So we thought we could do that with the p-value. Right, that things like the p-value and the confidence interval would just get rid of all that chance stuff and sort it out for us. And that's how we've been going along. But unfortunately, oh God, we were wrong, and it's just so wrong. Why were we so wrong? And this is it's not our fault. We were trained poorly, and so you know, no one's to blame. But we need to fix this. Now, firstly, our standards are too low. Now, if you look at the Higgs boson particle that the physicists investigated and I think found in a large hadron collider in Switzerland, I believe, when they were trying to determine if it exists, right? They used a p-value of 0.000003. So, you know, assuming this is about chance variability, there's a 1 in 3.5 million chance that could happen by chance, right? So we instead, now they're just dealing with an infinitesimally small particle of no real significance to a human being right now, whereas we're dealing with people's lives, and we use a p of 0.05 and give it a 1 in 20. We could be wrong. Now, if only that were true, and it was just 1 in 20, everything would be okay, probably, but that isn't true. Secondly, the p-value calculation, as I said, assumes zero risk of bias. Now, what people don't realize, and I didn't realize so quite recently, is that the p-value calculation is not just a test of the null hypothesis, right? There's this whole system that we're using of significance testing of the null hypothesis is we've all thought, or we've been kind of focused on the fact that we're testing one hypothesis that the null hypothesis is true, right? That there's no difference between the groups, and that's all we're testing. But actually, we're not. That's just one assumption that we're testing. We're testing that assumption and a set of other assumptions simultaneously, collectively as one test. And one of those other assumptions is that there is no bias, right? That this is a completely random sample from start to finish, everything's been done well, and that all you're seeing is a perfect representation of the data set. And so one of the sample assumptions is there's no bias. Another assumption is that the null hypothesis is true. Now these are all equal parts, equal assumptions as part of the calculation, and the calculation is testing all of them simultaneously. So if you get a p of 0.04, whatever, if one of those assumptions is not true, then that p-value doesn't mean anything anymore. It completely invalidates the calculation. So the calculation only made sense if all the assumptions held true, and it doesn't if one of them, the biggest one, bias, doesn't. And so we've been accepting these p-values, these marginal p-values in studies riddled with bias. They go, well, it's less than 0.05, a little bit of bias, that's okay. No, the bias affects the validity of the calculation. And this has, I think, been lost on all of us, and me definitely, until quite recently. But the biggest problem is that we were just fundamentally wrong about what the p-value means. And it was all of us. Every doctor, every scientist was wrong because we were taught wrong. And it's, again, not our fault, but here we go, it's about to change. So when did this first change? And by the way, guys, if you've got any questions, please feel free to shoot them in the questions box, and I'll answer them at the end, but so you don't forget them. Feel free to ask them as you go along. So this was a landmark paper by Regina Nuzzo, a professor in statistics. Right? So somebody actually understands statistics, and it was published in Nature, and to this date, I understand it's one of the most widely read Nature articles ever produced by Nature, which is obviously one of the most widely read journals ever made. So everyone's read this apparently, except for us, it seems, because we haven't changed what we're doing. And what just kind of awesome infographic that she showed, that I would just burn this into your heads. You don't have to. I'm going to give you a website after this that you can go look at this anytime you want to. But this picture tells the story, or part of the story, as to why we've been doing this wrong. So the issue is that p-values don't tell you the probability that that this finding would have occurred by chance. That's what we thought it was. We were all told that the p-value, if it's 0.05, then there was only a 5% chance this could be found by chance. And we then implied in our heads, I think, that meant there was a 95% chance that the finding was true. That's kind of what we felt about this p-value. That 0.05 meant 95% chance that we're on a win here. Now the problem is that isn't actually what the p-value means. The p-value is best understood using kind of Bayesian mathematics, and the concept is that it's a likelihood ratio. The p-value is a likelihood ratio that converts a pretest probability into a post-test probability. So as you can see from this example, if you look at the long shot, where before you enter the study, there's a 5% chance that this is a real effect, and I would suggest to you all that we should probably use the 5% for most of our studies, and I'll probably maybe explain why in a second. But 5% chance of this being a real effect, and then you do the study, and it comes out with a finding, and it says a p is 0.05. Then that just changes that 5% chance into 11% chance, not 95%, 11%, which is just a totally different percent. I mean, it changes everything that we thought. And even if you had a much better p-value of 0.01, it changes your 5% to 30% chance, still 70% chance that this is untrue. It's hard for me not to get excited, because this is kind of brain smashing revelations that basically blew my mind at the time, and I'm trying to hopefully blow yours. Now, things get a little bit better if it was a 50-50 toss-up before you started the trial. If for some reason there's loads of evidence before suggesting, yep, oh, it looks good, yeah, it looks like it might work, but they're all small studies. Here's the one big study, and you do it, and you go, oh, it's probably 50-50, and you get into the study. Well, yes, you're 50-50 before you started, and a p of 0.05, you get up to 71%. A p of 0.01, you get up to almost 90%, which looks really good, right? Now, the issue is that that's really almost never the case. Like most of the time when we're doing studies, there's very little chance that it's going to be a real effect. And partly that's just because all the greatest treatments and the easiest things to find happened 30 years ago, right? Antibiotics, vaccinations, public health, like that was all the low-lying fruit where we made the big differences, the very low NNTs for benefit, right? Now we're just trying to find these tiny benefits, then spending loads of money trying to find drugs that just give you a little bit more here, a little bit more there, because it's really hard to find new awesome drugs. And so most of the time, we're not going to find a benefit. And we really should be starting with the baseline, I think, pretest probability, more around that 5% when we walk into studies. And only after a couple of studies have started to show some findings that we start moving up the scale to maybe a pretest probability before the next big study of, maybe 50%. And then we start talking about really likely probabilities after that. So this kind of graphic is kind of the game-changing graphic. And just if you can't remember what a likelihood ratio is, this is a Fagan nomogram that is how you use likelihood ratios, right? And it's likelihood ratios, when we talk about tests, are a combination of sensitivity and specificity all rolled into one number. And so this, for memory, was actually a likelihood ratio for a negative D-dimer in PE. So if you get a negative D-dimer and your pretest probability was 10% and you follow the blue line, your post-test probability after D-dimer is less than 1%, right? Now, which is great. You're done. You're under the test threshold. You're out of here. No more PE testing. But if you started with a pretest probability of 90%, then it only takes down to 40%, which is not good enough. We still need to go further, and we'll do a CTPA. So we'll skip the D-dimer entirely, which is what we'll do. So that's just a kind of quick recap of how likelihood ratios work, how they all depend on the pretest probability. with just like the p-value. The p-value is that middle line. It's a likelihood ratio, but not those numbers. And I'll show you what the numbers are later. So now they've showed us that they're just likelihood ratios. And also, I still think this probably grossly overestimates the likelihood of being true. So these numbers, these appalling post-test probability numbers, are actually still optimistic. And why? Because, firstly, the numbers that they use, the likelihood ratios that you convert the p-values to calculate those numbers, are the best possible likelihood ratio. So they call the maximum ratio. So they could easily be a lot less than that, and I'll explain that in a second. And the second thing is that presumably assumes no bias, right? Because how could you price bias into that? So that calculation assumes that you have the perfect study with no bias. If you have bias, that's suddenly become grossly optimistic, and unfortunately, most of the studies have bias. So those are really optimistic, in my mind, estimates. Now, how do we convert p-values to get those numbers? Well, there's something called the Bayes factor, which is just the likelihood ratio, basically, and it's just an odds ratio. It's a likelihood ratio. And there's a great study published this year by the American statistician, which I'll talk about in a second, and it's given us an exact Bayes factor to use for every p-value that you might think of, and that they call these max Bayes factors, as in, and they actually call them Bayes factor bounds, as in this is the upper bound of the Bayes factor. It could be a lot less than this. So this is the max. This is the best case scenario, and still not taking into account bias, right? So which makes it even more the best case scenario. Now, if you have these numbers, you can actually get onto an online calculator, which is also linked on the website I'll give you, and you can just punch these in yourself. So you can get one of these p-values and take a pre-test probability, and you go, oh, I reckon there's a 10% chance of this being true before the study, and then punch in one of these Bayes factors, and it'll tell you what the post-test probability is. So you can calculate these for yourself. But if you just don't want to do any of that stuff, I've done it for you, and here's a table which will be on the website, where you can actually look, if you had a 5% pre-test probability, or 10%, or 20%, or 50%, how do those p-values change to post-test probability? So you can always just look at this table to get a rough idea of what that p-value means, assuming no bias, and this is the best possible outcome. So now, how did we get the p-value so wrong for almost 100 years? So basically, Ronald Fisher is not actually the brain, but he's the guy who introduced the p-value in the 1920s, and he basically said that this was just a way of finding a finding, or looking at a finding and saying, this is worthy of a second look, not the touchdown slam dunk that we would take it to be with statistical significance, but you know what, that's interesting, let's have a look at that in another trial and replicate it. And then these other guys, these other mathematicians, Neyman and Pearson, created this rigorous rules-based approach to evidence-based assessment, and which is good because you need to have rules. Otherwise, it's just a complete everything breaks down, which it already has despite the rules. And so they created these fixed rules, and Fisher created this. Yeah, it's worthy of another look. And then allegedly they had a public feud where there was apparently name calling in the literature, and it sounds amusing except for the result, which is that when they were feuding and no one was writing anything, some non-statisticians then wrote books, and they combined the two approaches, the second look, into fixed, rigid rules. And the p-value and the 0.05 and all that became part of the rigid rules. And it never was meant to be. And that's how we got here. So what happened after this? So that Nazar paper was 2014. And one of the most read papers around, and we didn't listen. No one changed. We kept publishing the same old rubbish with the same old p-values and p less than 0.05 stuff. So the American Statistician, which is the journal of the American Statistical Association, this is the biggest group of professional statisticians, the most well-respected group in the entire world, have published this key paper about the p-value, because it was enough. It was enough. We need you guys to understand that the p-value is not what you think it is. So, and what they were trying to solve was this circular problem that is that, why are the universities teaching p of less than 0.05 as being something important? And the answer was because that's what they do in the actual, scientific community. And they were like, why is the scientific community doing this? And it's because that's what they taught me in university. So this circular problem had to be broken, and in entered the ASA. So they made some key statements. 1, p-values do not measure the probability that the studied hypothesis is true, or the probability that the data were produced by random chance alone, which is kind of, hello, exactly what I thought the p-value was my entire medical career, right? I probably the same. And so that kind of blew my mind, and realized that, you know, we need to start from scratch. And scientific conclusions or policy decisions should not be based on whether a p-value passes a specific threshold. So p.05, not important. P-value or statistical significance does not measure the size of an effect, and we kind of hopefully knew that already, although some people would often publish really small p-values trying to say, look how great this is, and it doesn't make the actual significance anymore in terms of clinical. And the last thing is, the p-value does not by itself produce basically a good measure of anything. And so it was pretty damning about the p-value, you'll probably agree. So they published that in 2016, and we didn't listen still. And all the major journals kept going on despite the authority on statistics telling us to stop what we're doing. So they published again last year, which kind of prompted me to kind of do this talk and start looking into this more. And to me, this is kind of the metaphorical equivalent of them screaming at us. You know, they're like, you're not listening to us. Please stop what you're doing. And so here we are. They've come to tell us again for the nth time, please stop doing this. No, don't base your conclusions solely on whether an effect is statistically significant or not. Don't believe an association effect exists because it was, but equally, don't believe that it doesn't because it wasn't, right? And we'll talk about an example of that in a second, that just because you don't get near the 0.05, that doesn't mean it's not important. We might need to restudy it, but we need to take it on board as an important finding. And again, don't believe your p-value gives you the probability that chance alone produced that effect, or the probability that your test hypothesis is true, which is kind of what we thought. We thought that p of less than 0.05 meant 95% chance that this was true. All wrong. And don't include anything about scientific or practical importance based on statistical significance or lack thereof. So pretty damning. Big shout out to every guideline committee, every approval authority like the FDA, to just basically stop doing what you're doing. Now, but their main recommendation, drum roll, don't say statistically significant. So there's this big section saying, can you just stop it? All right, no more. The term has to be retired. Never say it again, please. Don't say statistically significant again. It is meaningless, and it creates all the problems that we're finding right now of p-hacking about some arbitrary threshold that just means nothing. It's just a likelihood ratio, and you need to apply it to a pretest probability, and by itself it's meaningless. And so no p-value can reveal the plausibility of your findings, whether it's above or below any particular threshold. And therefore, a label of statistical significance doesn't mean anything, and a label of non-significance doesn't mean anything. So what do we do now, right? We've had our minds blown about the p-value. We've just had to relearn it. And so how do we go forward? So they actually, that whole publication was a whole month's edition, trying to give us some alternatives. What can we do next? Okay, because everything looked pretty bad and bleak. So they said, firstly, go back, the atom principle. The atom principle is accept uncertainty, be thoughtful, be open, and be modest. And I'll tell you what they mean by that. So accepting uncertainty, then this is wonderful quote where they say that basically statistical methods are often sold as a sort of alchemy that transmutates randomness into certainty, an uncertainty laundering that begins with data and concludes with success measured by statistical significance. Just wonderfully captures evidence-based medicine as I understand it. And you know, it's just not the case. You don't go past the threshold and suddenly go, this is true. All that happens is that you move from one level of uncertainty to another level of uncertainty. Life is about uncertainty, and medicine and treatments and whether something works is all about uncertainty. And we'll talk a bit more about how we're going to deal with that uncertainty. So with this new outlook, we really need to seek out replications to take us progressively so that we're less and less uncertain about something before we decide to try it. So going back to the likelihood ratios that were shown by Nato, and how p-values can convert pretest probability into a post-test probability. With each successive trial, you can move from, say, an initial pretest probability of, let's say, 5%, and then you do a trial and it has a p-value that's okay, and until okay, now our pretest probability has moved to a post-test probability, after trial number 1, that's higher, and then you do another trial and it takes you even higher, and so just replications that take us to that highest level of certainty that we need for as to change practice. Now, they said be thoughtful. Be thoughtful about what? Well, be thoughtful to evaluate research findings based on the practical, so the clinical significance of the estimate, the precision, so things like the p-value have some importance, the plausibility of the findings. So is this biologically plausible, or is somebody making up some magic effect? And that biological plausibility feeds into pretest probability. Right? Pretest probability is basically biological plausibility plus all the evidence that's come so far in preclinical studies and other observational data. You put all that together, and that gives you your pretest probability. Replicatability, right? So how replicatable is this? It's the cornerstone of science, is that you have to replicate findings to believe them, regardless of your p-values. And the other big one is, what do we already know, and how certain are we in what we know? Now, as I said, pretest probability equals biological probability and prior research. And so we need to know that before we can interpret anything. Now, pretest probability, I want to give you some examples of trying to make them up for yourself, right? So if you looked at thrombolysis for stroke, you might, if you then did the last big trial, which I think was IST3, before it came 12 trials, 10 showed harm or no benefit, and 2 showed benefit, and were quite significant amounts of bias in those 2 trials. You also have the situation where thrombolysis in MI, where we did the studies in MI on like 60,000 patients, were for fresh clots that just formed, whereas stroke has many embolic clots, right, which thrombolysis shouldn't work for at all, right, because they're all clot or atheroma that's never going to respond to thrombolysis. So on a kind of biological plausibility, it was unclear whether this was going to help a lot. And then people said, forget about those 10 trials. We'll only look at those 2 trials, because they're the only ones that use the agent in the way that we want to talk about. We're going to ignore all the others. But then, from a biological plausibility perspective, you went, hang on a second, when we looked at the thrombolysis for MI, all the thrombolytic agents, had the same benefit. So why should we just exclude all those 10 trials when we never did that with thrombolysis for MI? So if you put all that together, you could argue that the pretest probability that thrombolysis would work for stroke based on the studies available and the kind of physiological plausibility was fairly low. And then if you then add another trial to that, you should interpret that trial's findings based on that pretest probability. Now, all of that is obviously debatable, but that's just one way you might go about assessing pretest probability. Another one that's a really good example that came out last year is the CRASH-3 trial. Now, the CRASH-3 trial is a trial about thrombolysis, not thrombolysis, I get that off my mind, is about tranexamic acid for head injury, right? Now, tranexamic acid has been used for a little while now for major hemorrhage, of which the data is not that strong, by the way. But anyway, we use it in a major hemorrhage, and then we thought, why don't we see if it works in blunt head injury, right? And we found an NNT of 77, so one of these very small numbers that worries me about the old double whammy, the EBM double whammy, or not actually being a real finding, and a p-value that was borderline, right? Now, in fact, they didn't even publish the p-value, because this journal has already started realizing that p-values are a bit silly, and instead published confidence interval, which is exactly the same, right? So the 95% confidence interval is exactly the same as having a dichotomous you're in or you're out p-value of 0.05. It's the same concept, and we need to stop those arbitrary thresholds. But anyway, you could imply from it, because it was right on the confidence interval, that it was probably a p of equal to 0.05. So not that impressive, if you remember those NUZO pictures. So, however, if you looked at the pretest probability, now when we look at TXA in blunt head injury, when you get hit in the head really badly, you die for many reasons, right? Diffuse external head injury, all these reasons that your neurons get destroyed, you die from. But one of the reasons you could die from is that you start bleeding a lot. And the TXA would only really help that. It would never help any of the other reasons for dying. So maybe some of the people might benefit, right? But we just did a trial before that called the TITCH2 trial, which was for spontaneous intracranial hemorrhage, where people start bleeding in their heads, right? Spontaneously. Now, all those people die because of bleeding, right? Every one of them dies because they're bleeding into the head, right? Or some of them might have had a seizure, but most of them died from bleeding into their heads. So in a trial where the main cause of death inside your head was bleeding, there was no benefit from TXA. And I want to be clear, we shouldn't really be talking about positive or negative trials anymore. They're all just different levels of uncertainty. But you've never seen 2 data sets more similar between the treatment group and the control group. It was like they were twins. There was just not a signal of benefit in any subgroup for benefit, right? So you've got a finding that says that TXA doesn't work when you're dying from blood in your head. And then you take it to a study or blunt head injury, where you're dying from all these other reasons and bleeding. The pretest probability was minusculely low before you interpret the CRASH-3 trial. So you take a really low pretest probability, you take a really subpar p-value of 0.05, and you have barely changed that pretest probability. The likelihood of that being a real finding is exceedingly low. And one of the reasons I want to give this talk is I still keep reading blogs around the world that are talking about this as being a useful finding that we should give TXA for head injury. And I just can't say strongly enough that that is not shown by that data. Now, another thing to consider is we have to look at different ways of deciding. So if you've got a new treatment, you need to wait till it's proven itself in many trials to say, yes, we should bring this in, because the alternative to that is do nothing, right? And our motto is first do no harm. So we should do nothing and only do something if we've proven to an acceptable level of certainty that it works, right? And has low harm or acceptable harm. But unfortunately, we get a lot of decisions in medicine which are about two things that are, kind of equally viable, right? And or that we might have already been doing and was a kind of a standard of care. We're trying to choose between them, right? And in that case, it ends up being the old weight of evidence seesaw, where we just have to kind of see, what the weight of evidence is for each of these two things. And that comes back to one of their statements from the ASA saying, what do we already know? How does this fit into what do we already know beforehand? And so, one of the things that I often talk about is fluids in septic shock, fluid resuscitation I'm talking about, as opposed to just slow rehydration, which is probably fine. But resuscitation, where we're actually giving fluids quickly to try and boost our blood pressure, etc. And we've got basically a situation where we had basically no evidence at all of any quality showing that giving fluids for resuscitation was beneficial. And then we had one big randomized control trial and a bunch of observational data, which is not that strong, but one huge randomized control trial showing that it killed people. And people said, oh, well, now we've got equipoise. And I'm like, what are you talking about equipoise? Now we have basically nothing outweighed by something. And at that point, I feel that's the point that you change evidence based on what you know already when you're dealing with between two fairly comparable therapies. And so another example of that is in current COVID-19 is the management of severe hypoxia. We had this over decades kind of started not intubating people and using non-invasive strategies for people with severe hypoxia, and we feel that's better, and quite a bit of data in certain conditions that shows that's better, but in viral pneumonia, not much good data. And so when COVID came along, because we were worried about a few things, we went, actually, early intubation makes more sense. And we started intubating people and not doing NIV and HFNC. Now, that was based on almost no data either, really weak data. But, in good conscience, was made for some, decent reasons. And then we started seeing all these people dying from early intubations, at least from case series that we've seen. And so what we've got now is some data showing that this is really bad. And some data, which is even probably slightly weaker, showing that maybe it's a good idea. And as a result, the seesaw tips, right? But both of these are weak. But it's just balancing the two, and we now takes us to revert back to what was our standard of care of NIV and HFNC. So sometimes it's not easy. We don't have great data on either side, and it becomes the weight of evidence seesaw. So be thoughtful. Now, they say careful consideration of the definition of a meaningful effect size communicated prospectively. Now, best example of this is the redback spider trial, the RAVE2 trial, where they were looking at redback spider antivenom and to see if it helped your pain, right? And what they found was that 11% of patients had a clinically severe improvement in pain at 2 hours, so an NNT of 9. That's pretty good, right? But with a P that was only 0.1. Now, they decided before the trial that they would only accept an NNT of 5 as being relevant and powered the study for that, and then it got stopped early because they ran out of money, which happens all the time. So their conclusion was the addition of antivenom to standardized analgesia in patients with redback spider bite did not significantly improve pain or systemic effects. Now, that's technically true when you use the term significant from statistical significance, which we're never going to use again, but it's just completely inappropriate. There's a clear signal of benefit here with a rubbish p-value, and all that means is there's a signal of benefit, we need to study this again. Right? Now, they did communicate that prospectively, I understand, and so that they ticked all the boxes, but the question is, was it a meaningful effect size? Is the NNT of 5 a reasonable thing to power your study for? Now, I point that out because I understand a major guideline in Australia that's going to now recommend against redback spider bite antivenom based on this. And as the ASA have said, you do not discount findings because they don't cross that magical statistical significance threshold. In fact, you never use that word again. So be thoughtful. Consider real-world costs and benefits, right? Benefits such as So when you're thinking about practice change, you've got to think about obviously what's the benefit of the drug in terms of life extension, other morbidity improvements, but also what are the balance against the risk to the patient. But what are other costs to the patient? It might be an evasive operation that you're talking about, evasive strategy that has significant, at least inconvenience or possible risks to them, but also financial costs to both them and the system, right? All of that has to kind of be put into an equation, right? And so when we decide about when we're going to change practice, it's going to be different for different therapies, right? So for a new therapy, a new drug that's come out, that's going to be horrendously expensive, and almost certainly going to have a very low benefit because all the great benefits were found 30 years ago, with a few exceptions coming out these days. A low kind of benefit, and I say net benefit, so benefit over risk, and a high, really horrendously high cost. We're going to really want to have, a certainty of kind of near 100%, 90, 95, 100% before we're happy to say, yes, we're going to change practice and bring that drug in and start using it, right? Whereas if you've got a drug that is really cheap and seems to work and has basically no downside, then you might change benefit before this. And I'll give you an example. So paracetamol, IV paracetamol, there's 3 studies, one very large, that showed that a rapid infusion given over 3 to 5 minutes, so just run the bag in, stat, was as effective as morphine in renal colic. Right? 3 studies, okay? And one of them's pretty big and pretty good. Now that, with those 3 studies and their p-values, I don't know, let's say that now our pretest probability of 5% has become 30, 40, maybe 50%, right? But let's say it's even 30 or 40%, right? That still might not be true, but it's basically costs $2 now, at least in my country, Australia, and it's harmless. It was done in people under 65, and no one had any problems in adults under 65, and it allows you to use less opioids, because if you give ibuprofen rapidly and it works really well together with other medications, you can then not use opioids, which are a bigger problem down the line. So for me, I could make a case that even 30, 40, 50% certainty, I might change practice for a basically harmless drug, which can help me create benefits, and wait for more data and change practice now. You can make that case. Whereas for a new drug, or say, thrombolysis or something like that, you really need the highest level of certainty before you change practice. This is a certainty change model that I propose. So the last few things about being thoughtful they said was be thoughtful and clear about your level of confidence or credibility. So that's why they said stop using significance and confidence, because they are misleading terms. And Goodman said something very interesting, that maybe every researcher, when you make a claim on your study, you put your p-value, accompany that with the estimate of the chance that the claim is true. I.e., take that Nuzzo paper or the table that I'll give you and go, what is my postage probability that this is actually true? Now that would be useful to publish. And so there's 2 ways of doing it. What are the alternatives, right? They say, look, we bang on about the p-value, but what are we going to give you instead? So there were loads of alternatives in their papers, and many of them I just don't understand, and I'm not sure that we'll find them useful. But there were 2 that were useful. So one was publishing the p-value next to that Bayes factor bound that I mentioned before, right? That likelihood ratio. So this is the p-value that equates to this likelihood ratio. Now go nuts, you people, and decide what you think the pretest probability was, and work out a process probability and decide whether you're going to change practice, right? So that would be very transparent, and I think quite a fair way of publishing things. And you still have to obviously go back and think there's any bias, but not a bad step forward. The other one would be to combine the p-value with the actual minimum false positive risk. And what that is taking that Bayes factor, taking that p-value, and going, what's the best case scenario before we're doing a trial? The absolute best case scenario was that you've done a bunch of earlier studies and they all showed a bit of benefit, and so now you're doing a good big study, and it's maybe 50-50 at this point whether it's going to work, right? And so you could that toss up in the middle here. And so that's the best case scenario, is a 50% pretest probability. And you take that 50%, you apply the p-value, you get a false positive, what is the minimum, what is a false positive chance, right? And that is the minimum false positive risk, because you've taken the most egregiously high pretest probability that you could take. You've taken a Bayes factor, that's the maximum possible Bayes factor, and you assume no bias. So 3 things that have made this the highest, the slowest possible false positive risk, also called the false discovery rate, and publish that. And that would not be unreasonable either, because you'd go, right, p-value, minimum chance that we're wrong, but knowing those 3 things I just talked about, it's probably much higher than that, but it gives you kind of a lower bound of wrongness, if you like. That, I think, is, minimum false positive rate, not a bad idea. My concern is people will stop remembering the word minimum and start thinking it's the actual false positive rate. Then be open. So we did atom principle, accept uncertainty, be thoughtful, tease out all the T's. There's not many O's. These are the only O's here. So be open to open science practices. That means public pre-registration. Everybody has to pre-register their trials and be completely transparent in when you're reporting. Share all your data or your patient-level data. Best examples of this are Tamiflu, right? What a disgrace, right? It would thought it was meant to help and improve us and reduce complications. And for like a decade, the BMJ editors were like banging on to the drug companies, give us the patient-level data, give us the patient-level data. Finally, after they sold billions and billions of dollars of it, they gave them the data and they looked at the data, and there's no benefit for reducing complications. I mean, it's an utter outrage of how much money we've all wasted in all our countries on Tamiflu to thinking it's going to reduce complications. And that's because they just were not open with the data. Now, statins, and I mean, you can argue other benefits of Tamiflu in terms of reducing disease, illness, etc. But in terms of the big thing that we were thinking about in terms of reducing complications, it was not there. And that is unfortunate because we spent a lot of money on it. Statins, right? Controversial area. Statins for primary prevention, secondary prevention, maybe they work. You've had a heart attack, take a statin, see if I care. But if you haven't had a heart attack and you want to take a statin just because some number in your blood says it's high, the cholesterol, which statins might not actually be working through that mechanism to help you anyway, but another topic. But we're told that you've got high cholesterol, take statins. Now, the benefit, even kind of the optimistic measures of the benefits are fairly small, right, in terms of reducing your risk of an MI, etc. But they're there if you look at, allegedly there, if you look at the published data. But the statin data, almost all the statin data, came before the clinical trials registry. So therefore, what are the chances that there are studies that were done on statins that had harm or no benefit that were not published? In my mind, basically 100%. Like there's basically, it's almost certainly true that there were other studies that didn't show what the drug companies wanted us to see, and they just didn't publish them because they had no reason to, and they never had to pre-register their trials. And what are the chances that of those studies they were harmful? Almost 100% or no benefit. So you, in my mind, people say you can only interpret the data you've got. No. Now we're talking about overall probability of this being true. So when you're looking at this and look at the current data that we've got and look at the chances of benefit, it being relatively small, and then you go, well, now we have to price in all the stuff that we can't see. And because this was back in the old days when they didn't have to register the trials, we have to assume there are other trials out there that showed harm or no benefit. And when you then price that in, it makes it very improbable. If you price that in, very improbable that they have a benefit in this area, in that particular area. So that sounds controversial, but I think that's the only way we can deal with this is we have to estimate what we really think the probability is. And therefore, I think that might have to be reevaluated. We'll talk about that at the end. Be open in reporting. So obviously just don't report P less than 0.05. If anyone ever does that again, I hope they never get published. But obviously you have to show the exact P value. And ideally things like the base factor or the minimum false positive risk. And to avoid publication bias, that means you need to publish everything. So not just the outcomes that you wanted to, but the outcomes that were all there to see, and all the studies that were not shown before. So, and the last thing is be modest. This is the M. Be modest in your conclusions and limitations regarding the study. Don't make wild claims that this is the drug that's going to save lives, or is it, the Crash 3 trial, they've said that the balance of, I think something like the balance of probabilities is more likely than not that it would be beneficial. That might have made sense in the old evidence-based world, but not in the new evidence-based world that we're talking about now. That is not the balance of probabilities. It's unlikely to be effective. So after this all came out, a large group of scientists signed a big petition to basically call for the end of statistical significance, as the ASA has, and as I am, and as we all should be. It should be retired. Please don't ever use that term again. If you do, I will hunt you down, okay? Don't ever use that term again. Now, what now? EBM 2.0. EBM 2.0 is what I was introduced to you, which is putting us all together as to the way forward for all of us. We're almost at the end. We are now in a post 9/11 world of EBM. And what do I mean by that, right? September 11th, 2001, was it? September 11th, on that day, obviously a major event happened in America. And the day before that, if you took a person the day before that on September 10th, and they want to have a conversation about global security, let's take that person. And then you take a person on the 12th of September, and they want to have a conversation about global security. So those two people from the 10th and the 12th cannot even have a conversation They can't even begin a conversation if they don't know about, if one of them doesn't know about September 11th, because that was an ultimate game changer in global security, right? So they can't even have a conversation. We are in that world now. Now that you have heard this information, you know what the ASA is saying, and NATO is saying, and all these publications are saying, you are now in a post 9/11 world of EBM. There's been a game-changing event in EBM that you can't, and I can't have conversations with my colleagues about evidence anymore, because if they don't know this, they're talking about a whole different world that I'm talking about. And so we have to change that by spreading this message so that every doctor in the world knows about EBM 2.0, and that we all move into this post 9/11 world together, that we've all taken that red pill that you've taken now. Sorry, you can't go back to the matrix. You're in the real world now. And what we must prevent, now I call this talk evidence-based fraud, right? And in fairness, and while there are definitely institutions and researchers who have been guilty of fraud, that they just call methodological errors or bias or whatever you want to call it, but some of it is, in my mind, fraud, and people should go to jail for it, but they don't. For the most part, most people have been making mistakes based on just information that was wrong and a misunderstanding of the p-value and statistical significance, right? So it's really just deceit. It's not fraud, and it's been unwilling deceit. We were deceiving ourselves. We didn't even know that, right? And unfortunately, our patients as well by extension. But now that we know this, if we continue on this way, then it is fraud. Then what we are doing is fraudulent, and we should hang ourselves heads in shame. And it's time that we all change and told everyone about this so that we can all change. So as I said, you've taken the red pill. You can't go back. So what are the key principles of EBM 2.0? Closely review studies for any sources of bias. But like we already have been doing in EBM 1.0, hopefully, but you have to assume there's some bias, because there's, as we talked about, there's some bias that you can't even see. So, know that those numbers that we look at, those false positive risks, the likelihood of being true are the best case scenario, and discount them in your head at least. With chance, forget about statistical significance. I will hunt you down, never use that term again. And know that the p-values are merely likelihood ratios, given the best possible study conditions with zero bias, which of course probably never exist. And the bias itself, particularly if it's any way significant, it just invalidates the p-value calculation. You can't even use it. And all you can do is say, look, that was a bias study. That p-value is basically meaningless. Let's wait for the next study. So, what are the key evaluation points when we look at studies now? Similar to the old, but a bit different. The big one is, what is the pretest probability, right, before this finding? And really, researchers who publish trials probably should be talking about that in the study, and probably should publish that when they register the trial, what they think the pretest probability is based on the biological plausibility and the previous evidence. And that would be useful to get their opinion, and then we should come to our own opinion as well, because we can't actually make any sense of this unless we know it. Was the risk of bias low? We've talked about that. How large was the finding, right? Is it really clinically significant, or is it the EBM double whammy of a tiny finding that is actually not true? Was there any statistical hocus pocus used to treat the data, like the attribution matching in the contrast studies, CT contrast studies I talked about before? Because if there is, you basically can't accept that data as being in any way relevant, and need to wait for further data. And has the finding been independently reproduced? So we've got to see it again and again, and that's one of the big criticisms of many of the recent studies that people talk about, is that they just never got reproduced. And are these findings certainly valid? So everything we've talked about is all about internal validity. This entire talk's been about internal validity. We haven't even talked about the fact that everything might be hunky-dory, right? Perfect study, lots of studies before, wonderful, great study, a beautiful p-value that's just so small I can't even read it. But like, it has this weird inclusion criteria or exclusion criteria that means the people that they study are totally different to the patients I see. So it has no external validity. So it's another problem like that we haven't even talked about, that just makes this even harder. And as we talked about, what are the practical benefits right now of changing practice? What are the real benefits and risks, and the cost of me just going, I'm 50% certain that's probably enough for me, and this cheap, harmless drug that we've had forever, versus this brand new expensive drug that's potentially risky. I need to be 95% more confident before I start using that. And last thing is, we've got to confront our past, because while we need to use EBM 2.0 methodology going forward, we need to look at our past and see who are the real suspects that need to be re-looked at and maybe re-studied. And these re-evaluations are not unethical. People will come out and go, oh, it's unethical. You can't take away this benefit that these patients are getting. This is rubbish. Clearly, on the new methodology, there's no proven benefit for a lot of these things. And some of the obvious candidates are, thrombolysis stroke, statins for primary prevention of heart disease. But just so it doesn't seem that I'm being biased against non-critical care studies, because I am an emergency physician, TXA for major hemorrhage, we love it. We all love it. It's cheap. It seems relatively harmless, maybe, but geez, I tell you what, that data is weak. And there's ways that we can restudy that, which would be ethical. But I won't talk about that now. Now, I'm not saying that any of the things don't work, right? Before every cardiologist and neurologist in the world come knocking on my door, I'm not saying they don't work. I'm saying on the EBM 2.0 methodology, there is no good likelihood, good probability that these treatments work for those conditions based on the available data and also the unavailable data, such as for statins. And therefore, they need to be further studied, is what I'm saying. If you want to use the EBM 2.0 methodology, then they remain not proven to a level of certainty that I think we should accept. That's what I'm saying. Not that they don't work, just that they're not proven. So, last thing is big picture goals. That we need to impress upon the journals is that if you're not pre-registered, you don't get published, right? So no paper should be published if they're not pre-registered, and no outcomes should be published if they're not pre-registered. And if you want to change a primary outcome, then you call it an exploratory outcome. You can never change your primary outcome. That's cheating. That's what introduces bias. Pre-registration, if you do pre-register, you need to publish it. We can't have 1/3 of trials not being published because we don't know what's happening with those studies, and that introduces massive bias. So how can we do that? Well, somehow we have to probably bring in some mechanism where people can just publish these trials that they have no interest in publishing in some kind of open source, probably not even peer-reviewed, place that people can at least access the data, so we can bring that into our data set of what we're considering. And similarly with their outcomes, anything you mentioned in an outcome, don't suddenly forget to mention it when you publish the paper. If you pre-registered it, that has to be there in the paper. And kind of big picture goals for the government is that we really need to compel research institutions to publish all trials legally. Like if you want to publish and if you want to experiment on a human being, you have to make that data available. There has to be a new normal going forward. And obviously we need more funding for research to minimize bias and to actually target the things that we actually want to study rather than the things that just make the most money. So the take-home messages are: be savagely skeptical. From now on, assume all study findings. When you really study, just assume the study findings are false, right? We want to believe they're true, right? We want to help our patients, so we want to believe they're true. But I'm asking you to believe they're false, and I want you to make the data wine and dine you before you believe it, right? Not just one date, one stage, a second date, a third date before you go home with that data, okay? Before you become a bedfellow with that data, I want several dates, okay? I want to be wined and dined with amazing data, low bias, great p-values, great pretest probabilities. Make the data wine and dine you before you believe it. And accept uncertainty. It's the nature of life, it's the nature of medicine. Everything's gray, and we just need to progress through different levels of uncertainty to whatever level of certainty is appropriate for that drug or treatment based on its benefits and harms and costs. That's the take-home messages. If you've got any questions beyond the ones I'm about to answer now, feel free to go to my main website, ED Guidelines, click on Contact Us and fill out the form, and I can email you back or hit me up on Twitter. And the last thing is spread the word. So if you believe in this and you want to change the world of EBM and make sure that we're doing the best for our patients, share this website, EBM 2.0, that I've created, which diverts to my main website and has all this data. It'll have a copy of this talk on it as well, and the video, and it will have, and if you tweet, you like tweeting, there's a new hashtag EBM2, which is about EBM 2.0. If you've got anything about this or in relevance to evidence-based medicine that needs to be criticizing a study because it's using the old methodology, hashtag EBM2. Make this a thing, make everyone know about it so that we can all change the way we go about it. So that's all I've got to talk about. Now it's time for questions. That was a long session. I apologize, but there's a lot to talk about and it was hard to get through any quicker.
Thank you, Anand. It's Beth here again. Thank you for that very informative and enthusiastic presentation. Yeah, there are a few questions there. I'm hoping that you can see them too.
Yeah.
Can you read them, or do you need me? Okay.
Yeah, I can read them, absolutely. So, first question is, if we're writing a paper, what statistics should we include in the paper? And that was, I think, probably asked a little while ago before I hopefully answered them. But I think the best things I would find would be the actual p-value. I think p-value is not of no value at all, but some value. And then things like the Bayes factor, if you next to it, as one of the major ASA publications said, put the Bayes factor next to it, and I can give you that table where you can calculate it it's on the website. Or take a step further and work out the minimum false positive risk, based on going in with the most egregiously high predictive probability of 50%, using that maximum Bayes factor and working that out. And we can talk about that offline in the way you can ask other questions. But those would be two of the leading ideas that I've seen. There are probably lots of other ideas, and I'm don't really like. I mean, if you want to talk about confidences, you can, but I don't like them because they're, again, dichotomous. You're in or you're out, just like the p-value less than 0.05. So if next question, the first one's from Alan. This is from Mark. If a p-value is derived without reference to a population being tested, why does it become a likelihood ratio, suggesting that it can be used to calculate a positive probability in a certain population? So I think you mean, and ask us again if I'm not answering it as you expected. I think you're talking about external validity. Like if the p-value is derived without reference to a population being tested, how can you use that to calculate the positive probability in a population? I think you're talking about it being, you're deriving it from a study in a population that's different to the one that you're actually worried about, that you actually treat. And of course, no, you can't. And that's why all you can do is work out, positive probabilities for the and all the positive probabilities are just giving you the likelihood of this working in that exact population that they tested it in. And then you then have to kind of make guesswork as to whether you think that number of certainty is going to translate anywhere near to that number in your population. I hope I've answered that correctly. Tell me again if I haven't. So from Jeffrey, this is all great, but what can we do in almost all journals and editorial boards are supposedly guilty of this? All we can do is spread the word, my friend. As I said, EBM 2.0, tell everyone, get everyone to know this. I mean, a lot of these editors don't know any of this stuff, right? Like, it's still very new. I only found this out last year. And I would assume in good conscience that if they knew all this, they would be wanting to change. And I know some of them already are, because as I talked about that crash 2 trial, they didn't even publish the p-value. But I think missed the point, because then they published the confidence interval, which is the same thing as using a dichotomous tool. So I think people want to change. I don't think these journal editors want this to continue this way. They've just been blissfully unaware, as we all have, right? Great. Thanks. And so next is another one. Should we just rely on our clinical acumen? If it works, it works. No. So we shouldn't, because that's still anecdote, right? And an anecdote is some level of evidence, but it's the lowest level, right? So we do need to study things, but anecdote is just not really not good enough. And if you look at the fluids and sepsis data, one of the greatest things about that data was that the trial that showed the harm actually showed us that the anecdote was wrong, because it showed us that we gave a big bolus of fluid, that everyone looked better and everyone got better and their blood pressure got better. They all looked great. We're like, yay, just exactly like the anecdotes. And then they died afterwards, right? A few hours later, they then died. And so, like, the anecdote was so misleading because they died later despite the anecdote working. So, however, if you've got nothing else, anecdote is something, right? And so, and the snakebite spider trial, redback spider trial, I think is a great example. That study proves nothing. There's a hint in the data that there may be a benefit, and it absolutely needs to be studied again in a larger population, and ideally just people with severe intractable pain, those people only. And but I've got loads of anecdotes of it working anecdotally, right? In people that are given IV, morphine, ketamine, everything, and their pain settles down and it comes back severely, and like, we can't give you ketamine for like 3 days. Let's try the antivenom. They're like, sure, and then after it just bang, like it's like magic, right? Now that's an anecdote. And it may not be true. And so, if you look at the thrombolysis studies, people have all these anecdotes of giving the drug and they suddenly get better. But guess what? Half of them, or maybe most of them, were TIAs, and that's what would happen whether you gave it or not. We've just got to keep doing studies. So what EBM 2.0 is not an argument to do less studies. It's an argument to do more studies, just high quality ones with no bias, and do it again and again to replicate. Shouldn't we just do case studies rather than RCTs? No, because they're even worse with way more bias and confounders. We need RCTs. We need, ideally, if it's possible, double-blind RCTs. And again, independently. This is the point. They're not enough. In fact, what this tells me and what this worries me about is all the other data that we look at, all that kind of social science data and stuff, which is like not double-blind RCTs or even anything close, it makes me worry that like most of that probably isn't true. You know, like I take everything else now with the biggest grain of salt because the gold standard type of study is it's only telling us a little bit of truth. That the lower than gold standard studies are probably telling us very little truth. Do these arguments apply to surgery, where we are still essentially in a very old profession, where arguably we still haven't found all things that work well 30 years ago? I'm not exactly sure what that means, but what I can say is it does apply to surgery, but surgery is tough, right? Because it's tough to do randomized controlled trials, particularly if you want to have a placebo arm, right? A sham surgery arm. It's not easy and sometimes not ethical. And I feel for you, and I don't have any easy answers except just to try, but also to assume that the data you do have is not as robust as you think it is, and be open to the possibility that things that you think are working are not, and try and study them as much as you can to be sure before you spend money or cut people, etc. Before you do things. I mean, it's tough. Surgery is tough. I think I was going to answer that question right. You're talking a bit extra. Thanks. Okay, great. Maybe we should. Maybe we should stop journals profiteering from papers being published and make everything open source. What a great idea. Geez, I thought some of my goals that I put up there were pie in the sky stuff. That's pie in the sky. But let's see what happens. Nice one though. Interesting presentation. Thank you. Oh yes. So thank you. Psychology undergrads know more about this material than most fellowship-trained medicos. I know this from experience in both fields. At no p-value, but query some bias. Time to shake up other health schools. Are you going to take this on? Yes, Anton. I would like to give this talk basically everywhere, right? So basically, I mean, medicine is my goal, right? And I'm sure loads of other people will take this up in other sciences. But medicine is my goal, that every doctor in the world needs to know this. Like, we can't go on without us all knowing this. And so we just need to spread this message wide and far. And I'm happy to help and talk and do whatever it takes to spread this message far and wide. So I understand that Dr. Senthi is discussing more of a paradigm for evaluating data, but I'm curious to think what he actually thinks about contrast-induced nephropathy, which I recently read a study review that suggests that sick people get renal failure in hospital regardless of whether they get contrast or not. So CN is probably not a big concern, and at risk of CSN shouldn't stop us from dying. Yeah. So look, my friend, I think the risk is probably really, really low, and I think there's every chance that it's not a real thing for CT contrast. Every chance, but I'm kind of guessing, right? And we're all guessing, and I think that the data that suggested that there's no risk is just patently absurd and not useful at all. Worth doing it, worth looking at it and going, well, that's interesting. And you know what it's useful for? It's useful for doing a randomized control. It's useful to give you the kind of ethical justification for doing a randomized control trial. Now, it's going to be hard to just randomize the contrast or not. But what you could do is you could do a study where, this is what I thought about a long time ago, let's say PE, that you have like a rule out, or you start a study where you're actually studying something else, right? You're studying whether or not the person should be investigated or not for PE, right? And you put them through some algorithm like the PERC score or something else, or some new version of D-dimer where you age adjusted or whatever, and you randomize one group to doing being ruled out from and one will ruled in, right? And so they're being ruled in to the diagnostic pathway and they're being ruled out of it, but otherwise are exactly the same people, right? And if you're ruled in, you have to have the contrast, and you go through, and now you've got basically two similar people, two similar groups, and I reckon that would be useful to see. But you need a massive study, unfortunately. But you know what? If you did a pretty big study and you couldn't see it, then the risk is probably small. And my bigger point about that is almost, not always, but almost every time that you're thinking about in contrast for PE or for stroke protocol or whatever, the benefit of doing that is almost always kind of massively outweighs probably any small risk that there is. So I don't get too hung up about contrast, but I've just be clear that the data to suggest that there's no risk is not valid. And why not advocate the use of publishing the p-value with upper and lower bounds of the base factor rather than just the best case scenario? Good question, Sam. So I thought about that, and the problem is I can't give you a lower, or I suppose a lower bound of the Bayes factor, and therefore an upper bound, or a lower bound of the posted probability. And the reason is, look, you could do it by saying, let's go back to that Nazo paper and go, the upper bound is, made by taking a 50% pretest probability, and the lower bound is taken by taking a 5% pretest probability, right? Now that would give you an upper and lower bound, or using, realistic assumptions of pretest probability. But what it doesn't tell you is there any bias in the study, right? So you've taken upper and lower bound on pretest probability, but you haven't decided about bias. And so you would then present that data and people go, oh, wow, all the likely possibilities of certainty are in this data, in this range. And we forget that actually half of them are not even inside that range because you haven't even priced in bias. So it worries me that will just become another de facto confidence interval. And in fact, why I kind of like, I mean, they've all got their pros and cons, and I don't know which one's going to work, to be honest with friends. But the minimum false positives I like, because you just go, this is the absolute minimum, and either you have to state it or everyone suddenly knows it, that there are big reasons why this is the minimum. One, we use the upper bound of the Bayes factor. Two, we didn't price in bias, right? So, and there's one other, it's not coming to mind. But so that's why I think minimum better, because you just go, look, the other side of this minimum, is, or false positive, is like 100%. Like the other side is so high that you have to be, very cautious about interpreting this. That's my answer, but I don't know if it's the best solution. Does this not point us from Gary point to just how incredibly difficult it is to produce high quality studies in medical fields? Yes. If things are to change, is it incumbent upon journals to massively cull the publication of terrible quality studies? No, and I'll come back there, which clearly they are financially disincentivized to do. So if they're poor quality, they have to be published. Now, and whether they get to get published in JAMA or New England Journal or any of these big studies, maybe not, but they've got to be published somewhere. And if they're published in JAMA, then there has to be an editorial with it saying why this is a poor quality study, why we disagree with everything in it. Maybe they just have a section at the back for all the studies that we think are low quality, or they go into some other open source, place of publication which is not peer reviewed. So you go, the guys that didn't even make it into these peer reviewed studies, journals, this is where they get published, right? So you take them with a fat grain of salt, right? But at least you got to see that data. The data has to be available to us. Otherwise, we can't price in citation bias. We can't price in reporting bias. We don't know which studies we never saw, right? So we've got to see them. They've all got to be out there. Everything has to be out there, but where it gets put and what you put around it and what disclaimers you put around it and in what format, that's what we have to debate. Out of interest, how long did it take you to do this deep dive and arrive at the revelation? And have you managed to convert your work colleagues? It's taken me quite some time. As you can imagine, statistics is tough. And I, was good at maths at school, but kind of left it there. I did some finance qualifications later, where I was, again, decent at maths, but geez, I tell you, statistics, some of these formulas are well beyond me. But so I had to kind of really dive through all this to find, people who were the best statisticians in the world, who were writing stuff that was actually understandable to use, and then be able to kind of obviously manufacture something that I could tell you that would be understandable as well. And hopefully I've achieved that. It was a deep dive, but an important one, and I don't regret any of it. And have I managed to convert my work colleagues? I don't know yet. I gave them this talk only a couple of months ago in both the hospitals that I work, and I hope I have. And our next kind of consultant education session, when we talk about papers, hopefully they'll all be on board. And so, but I can't answer that for you. How will studies need to change their designs to be able to incorporate Bayesian analysis? Should we be helping create frameworks of researchers for how to set up the initial trial to be able to do the analysis? I don't think so, because just from what I was reading, all the Bayesian stuff happens after, right? So you take your p-value and then you deal with it with the Bayesian analysis afterwards as a likelihood ratio, as that Bayes factor. So your designs can be the same. All that matters with designs is that they are, perfect. All that matters is they design them to be free of bias. And that we already know in EBM 1.0, everyone knows how to do that. But I don't need to tell people how to do that. Everyone knows how to do that. Some people just choose not to do that, right? And sometimes it's hard to do that. But whatever you're doing has to be mentioned, or whatever you're not doing has to be mentioned, so we can all make a decision about what bias there is. And so the best thing for research to do is just to design perfect studies. The only thing they need to change at the back end is how they report them and how they say their conclusions and what else they give you, like the Bayesian factor or the minimum false positive, minimum false discovery rate. So that is all the questions that we've got. If anyone's got another question, now's the time. But otherwise, that is our session. I hope that you enjoyed it and it has blown your mind and changed your viewpoints on EBM like it did mine. And I just earnestly implore you, now you've taken the red pill, get everybody else to take the red pill and go to ebm2.0.com and use the hashtag EBM2. What I'd like EBM2 to become like is like the FOAMed hashtag, right? When FOAM came out, they're like, this is amazing, free open access education, and everyone started talking about it and hashtagging it, but then they didn't do a hashtag FOAM because they would have got all the wonderful tweets about actual foam, so they made it hashtag FOAMed, ED, right? And that is what the hashtag is, and everyone knows what it is, and people have on their Twitter profiles, FOAMed supporter. Well, what I'd love is the EBM2, which we couldn't put EBM 2.0 because the decimal point doesn't work in Twitter. So it's EBM2, it's even shorter, becomes a key hashtag when we criticize or talk about studies using the old methodologies, and that people put in their Twitter profiles, hash EBM2 supporter. Like we need to make this a thing. So people know, well, what's EBM2? And they look about it and they go to these websites and they find out stuff. So please tweet, send this to all your friends, colleagues, and everyone in medicine. Not your people outside of medicine, because my big fear about people outside of medicine watching this is that they might actually start believing that nothing we say is true, and that's a concern. And the anti-vax problem will become an even bigger problem. But I will say this: that if we don't do this, we don't all spread this news and all don't change our ways. You can already see now, particularly in America, and it's spreading this great distrust in the population of bastions of authority. Like news channels, like doctors, like guideline committees, that is increasingly growing. And if we don't get our house in order and start sorting this out with EBM 2.0, then we are going to find that they'll stop believing all the stuff that we tell them, even the stuff that really, really works. And that will be a massive disservice to our patients. So it is ethically incumbent upon us to make this well known. On that note, we'll bid you farewell. Thank you for bearing with me, whatever time zone you're in. I really appreciate it, and please spread the good word. On that website will be this talk tomorrow. I'll have another video copy of it, and I'll also have I have lots of other stuff about this and the references, the key references that you can go check out yourself, and all these principles and stuff will all be there. And also Rural Health West, who were kind enough to make this talk available to everyone freely to join as part of their virtual conference. I'm also going to put this on their website, which I think is next week. And Beth, I think you can talk to that.
Yeah, sure. Thanks, Anand. And thank you for everybody who joined us this evening. We hope you enjoyed the session. Judging by the questions that came through, it looks like people couldn't get enough of the topic, actually. So I would like to say thank you to you too, Anand, for your time and being part of the Rural Health West virtual conference. And yes, we will post this recording to our Rural Health West website, and we expect to do that next week. So we'll let all participants know once that's been uploaded. So I will now close the webinar. Thank you, everybody.
Thank you for your time, guys.